Welcome to the Deep Dive. Today, we're really getting into something fundamental for clinical practice: blood tests.
Absolutely fundamental.
We've pulled together quite a bit of information. Our goal is to give you, especially if you're maybe a medical student just getting to grips with this, a really solid understanding.
hmm
We want to go beyond just, listing tests and actually explore why they matter clinically.
Exactly. Because blood tests, they're so much more than just, okay, what's the diagnosis?
Yeah.
They're crucial for tracking how a disease is going, for screening before someone even has symptoms,
Right, for planning treatment, too.
in planning treatment, assessing overall health. It's probably one of the most common lab investigations you'll ever order or interpret. But there's a lot of depth there.
Definitely sounds like it. Okay, so let's start with the basics. Why do we actually need blood tests? We know diagnosis, but what else?
Well, diagnosis is huge, obviously. Think about infections, anemia, high cholesterol, diabetes, checking organ function, kidneys, liver, even things like HIV or cancer markers sometimes.
So a massive range just for diagnosis.
A huge range. They help you figure out what's causing the symptoms a patient comes in with. But then beyond that initial step,
You mentioned monitoring.
yes, monitoring is critical. If someone has a chronic condition, say diabetes, you're using blood tests like glucose or HbA1c regularly to see if the treatment's working, if adjustments are needed,
Okay.
or checking immunity, have the vaccines worked. What's someone's blood group before a transfusion? That's vital.
And things like pregnancy monitoring.
Oh, absolutely. Regular blood tests throughout pregnancy are standard practice. For the mother's health, for the baby's development, early detection is key there.
So it sounds like they're used for finding problems early, even before symptoms, maybe.
That's the screening aspect. Checking cholesterol to assess heart disease risk, maybe certain cancer markers in high-risk groups, finding things before they become obvious problems.
And investigating symptoms. Like if someone feels tired all the time, you might check for anemia.
Precisely. Or even something specific like a pregnancy test, which is looking for a particular hormone in the blood or urine. And we're even getting into genetics now, using blood to look for mutations linked to certain conditions.
Okay, so a really broad utility. Now, for someone, say, a student on their first placement, seeing blood being drawn,
Yeah.
what's the actual procedure? How does it work?
Right. So usually it starts with identifying a patient, making sure you have the right person. Then you'll typically expose the arm, often the inside of the elbow, the antecubital fossa.
Okay.
Then you apply a tourniquet, a band around the upper arm. That makes the veins sort of pop out, easier to see and feel.
Makes sense.
Then, very importantly, you clean the skin really well with an alcohol pad or similar antiseptic.
Got to prevent infection.
Absolutely. Then you'll use a sterile needle attached to a special vacuum tube or syringe system and gently insert the needle into the vein.
And collect the blood into tubes.
Yes, you might need one tube or several, depending on the tests ordered. They often have different additives inside them, and there's a specific order you should draw them in to avoid contamination.
Ah, the order of draw. I've heard of that.
Exactly. Once you've collected the samples, you release the tourniquet before taking the needle out. Then withdraw the needle and apply firm pressure right away with gauze or cotton wool
To stop the bleeding.
to stop the bleeding. Then usually put a small plaster or bandage over the site. The person doing this is trained a phlebotomist, a nurse, a doctor.
And what about preparing for the test? Does the patient need to do anything? Like fasting?
Good question. Often no special preparation is needed, but for certain tests, yes, fasting is essential.
Which ones typically?
Things like blood glucose, definitely, lipid panel, so cholesterol tests, sometimes the basic metabolic panel or BMP. Fasting usually means no food or drink except water for about 8 to 12 hours beforehand. But the key thing is always check with the doctor or the lab. They'll tell you if you need to fast or if you need to adjust any medications you're taking.
Right. And does it hurt? People worry about that.
It's usually just a quick sting or pinch when the needle goes in. Most people tolerate it very well. If someone's nervous, looking away can help, maybe taking a deep breath.
Are there any risks? Side effects?
It's generally very safe. The most common thing is a little bruise at the site where the needle went in. Sometimes people might feel a bit faint, especially if they're nervous.
And serious problems?
Very rare. Things like significant bleeding, a large bruise called a hematoma, infection, or nerve damage are really uncommon if the procedure is done correctly. If bleeding doesn't stop easily or a big bruise forms, the patient should definitely let someone know.
Okay, so the sample goes off to the lab. Then you get the results back. Often it's a list of numbers in these reference ranges. How should a medical student start thinking about interpreting that?
Right, so the lab analyzes the blood for different substances, proteins, cells, chemicals, you name it. The results usually come back as numerical values.
And those are compared to the reference range.
Exactly. The reference range, sometimes called normal values, is established by testing a large group of healthy people. It gives you an idea of what's typical, but, and this is important, these ranges can vary a bit from lab to lab.
Why is that?
Different labs might use slightly different testing methods or equipment, or they might base their ranges on slightly different populations. So you always need to use the reference range provided by the lab that did the test.
Okay. And results might be flagged as positive, negative, abnormal, normal. What do those mean?
Generally, negative or normal means the result falls within that reference range. Positive or abnormal means it's outside the range, either higher or lower. Sometimes you might get an inconclusive or uncertain result, meaning it's not clearly normal or abnormal.
And results aren't always perfect, right? False positives, false negatives.
That's a crucial point. A false positive means the test suggests a problem when there isn't one. That can cause anxiety, lead to more tests unnecessarily,
Right.
and a false negative is the opposite. The test misses a problem that is actually there, that could delay treatment. These can happen for various reasons: limitations of the test itself, errors in collecting or handling the sample, or just biological variation in the patient.
You mentioned things that can affect results earlier, like fasting. What else?
Oh, lots of things. What you eat and drink, obviously. Medications, prescription, over-the-counter, even supplements. Exercise can affect some levels. Stress, for women, where they are in their menstrual cycle. Hydration status.
So it's really important to follow instructions.
Absolutely. Follow the provider's instructions carefully about fasting, medications, and anything else. And again, don't try to compare results directly if they came from different labs.
Okay, that makes sense. Let's maybe dive into some of the really common tests. The complete blood count or CBC. What are we looking at there?
The CBC is bread and butter. It looks at the main types of cells in your blood. Red blood cells first.
Okay.
It counts in the RBC count. Looks their size, that's the MCV, mean corpuscular volume. How much variation in size there is, the RDW, red cell distribution width. How much hemoglobin is in each cell, the MCH, and the concentration, the MCHC.
And what does MCHE tell you?
MCHC relates to the color. Low MCHC means the cells are paler or hypochromic, which you often see in things like iron deficiency anemia. These red cell indices, MCV, MCH, MCHC, are really helpful for figuring out what kind of anemia someone might have.
In hemoglobin itself.
Right, hemoglobin or HB. That measures the protein in red blood cells that actually carries the oxygen. We have typical ranges for males and females. Slightly lower during pregnancy is normal. Low hemoglobin means anemia. High hemoglobin is called erythrocytosis.
You mentioned some things can interfere with the HB measurement,
Oh.
like lipids.
Yes, certain things in the blood sample can mess with the lab machines. High lipids or lipemia makes the sample cloudy and can falsely increase the hemoglobin reading. High bilirubin, certain abnormal proteins, or really high white blood cell count can also interfere. It's good to be aware of those possibilities.
Got it. What else is in the CBC?
Hematocrit, or HCT. That's the percentage of your blood volume that's made up of red blood cells. It generally goes up or down with the red cell count and hemoglobin, low in anemia, high in erythrocytosis. Plasma volume changes can affect it too.
Okay. Red cells, hemoglobin, hematocrit. What about white blood cells?
Yep, white blood cells, WBCs. The CBC gives you a total WBC count. A low count is leukopenia, a high count is leukocytosis. But just the total isn't the whole story.
You need the differential.
Exactly. The WBC differential breaks down the types of white blood cells: neutrophils, lymphocytes, monocytes, eosinophils, and basophils. It gives you the percentage and often the absolute count of each.
And changes in those tell you different things.
Absolutely. For example, high neutrophils neutrophilia often points towards a bacterial infection or inflammation. Low neutrophils, neutropenia might be seen in viral infections or with certain drugs.
And lymphocytes?
High lymphocytes, lymphocytosis is common with viral infections, but can also indicate certain leukemias or lymphomas. Low lymphocytes, lymphocytopenia, you might see in conditions like HIV or with steroid use.
Monocytes, eosinophils, basophils.
High monocytes, monocytosis can occur in chronic infections or autoimmune diseases. Eosinophils often go up eosinophilia in allergic reactions or parasitic infections. Basophils going at basophilia is less common, but can be linked to certain blood disorders like myeloproliferative neoplasms. Interpreting the differential pattern is a really key skill, and watch out for spurious results sometimes due to things like clumped cells.
Okay, and the last part of the CBC.
Platelets. The platelet count measures the tiny cells involved in blood clotting. Low platelets is thrombocytopenia. If it's very low, there's a risk of spontaneous bleeding. High platelets is thrombocytosis. Sometimes you can get a falsely low reading pseudothrombocytopenia if the platelets clump in the collection tube.
Wow. Okay. A lot of information just from one test.
It really is. The CBC gives you a fantastic overview of the blood cells.
Let's move on to another common one, the basic metabolic panel, or BMP. What's in that?
The BMP, sometimes called UNEs or L-lights, gives you a snapshot of electrolytes, kidney function, and glucose.
So electrolytes like sodium, potassium.
Exactly. Sodium, potassium chloride, and bicarbonate, often reported as CO2. These are crucial for fluid balance, nerve function, muscle contraction, acid-base balance, really fundamental stuff.
And kidney function.
That's measured mainly by BUN, blood urea, nitrogen, and creatinine. These are waste products filtered by the kidneys, so if they're high, it might indicate the kidneys aren't working properly. The ratio between BUN and creatinine can also give clues, maybe about hydration.
And glucose is in there too.
Yes, blood glucose. It's a key test for screening for and monitoring diabetes. And remember, for an accurate glucose and sometimes the whole BMP, fasting is often required.
Right. Then there's the comprehensive metabolic panel, the CMP. How does that differ?
The CMP includes everything in the BMP, plus tests related to liver function.
Okay, so what does it add?
It adds proteins albumin, which is the main protein in blood made by the liver, and total protein. It also adds liver enzymes like ALP, alkaline phosphatase, ALT, alanine aminotransferase, and AST, aspartate aminotransferase.
And what do those enzymes tell you?
ALT and AST levels often go up when there's damage to liver cells. ALP can go up with liver problems too, especially issues with bile ducts, but also with bone disorders. The CMP also includes bilirubin, which is a waste product from red blood cell breakdown that the liver processes.
So the CMP gives you kidneys, electrolytes, glucose, and a look at the liver.
Exactly. It's a broader metabolic picture.
Okay. What about the lipid panel? We hear a lot about cholesterol.
Yes, the lipid panel checks your cholesterol levels. Typically, it measures total cholesterol, HDL cholesterol, that's the good one, LDL cholesterol, the bad one, and triglycerides, which are another type of fat in the blood.
And fasting is usually needed here too.
Usually, yes, especially for an accurate triglyceride level, which can affect the calculation of LDL.
Beyond just good and bad, what's the significance?
Well, high LDL is a major risk factor for atherosclerosis plaque buildup in arteries, so lowering it is a key goal for preventing heart attacks and strokes. Low HDL is also considered a risk factor, while higher HDL is generally protective. High triglycerides are also linked to increased cardiovascular risk, especially when combined with other things like low HDL or high blood sugar.
So you look at the whole picture.
Definitely. You interpret the lipid panel in the context of the patient's overall cardiovascular risk, things like age, blood pressure, smoking history, diabetes.
Makes sense. Let's talk about the thyroid panel. When would you order that?
You'd typically order thyroid function tests, or TFTs, if you suspect someone has either an underactive hypothyroidism or an overactive thyroid hyperthyroidism.
Based on symptoms.
Right. Symptoms like fatigue, weight gain, feeling cold could suggest hypothyroidism. Palpitations, weight loss, feeling hot might point to hyperthyroidism.
And what hormones are measured?
The main tests are TSH, thyroid-stimulating hormone, which comes from the pituitary gland, and usually free T4, which is the main active thyroid hormone. Sometimes free T3 is measured too.
How do they tell you what's going on?
TSH is usually the first thing to look at.
Yeah.
If the thyroid isn't making enough hormone, hypothyroidism, the TSH level typically goes up, trying to stimulate it. If the thyroid is making too much hormone, hyperthyroidism, the TSH usually gets suppressed, very low. The T4 and T3 levels then help confirm the diagnosis and assess severity.
Okay, clear. Now, cardiac biomarkers, these are for heart problems.
Yes, primarily used when you suspect someone might be having a heart attack on acute coronary syndrome, or ACS.
And the main one is troponin.
Correct. High-sensitivity cardiac troponin, HSCTN, is the preferred test now. It's very sensitive and specific for damage to the heart muscle. If it's elevated, it indicates myocardial injury.
Are there others?
Yes. BNP B-type natriuretic peptide, or NT-proBNP. These are released when the heart muscle is stretched, like in heart failure. They're useful for diagnosing heart failure and assessing its severity. Older markers like CK and CKMB are less specific for the heart and mostly replaced by troponin for ACS diagnosis.
And the timing matters with these.
Absolutely. Troponin levels rise over several hours after a heart attack, peak, and then gradually fall, so serial measurements are often needed.
Got it. Blood tests can also check for STIs, sexually transmitted infections.
They can, yes. Blood tests can detect antibodies or antigens for infections like HIV, syphilis, hepatitis B, hepatitis C.
Are there any caveats?
The main one is the window period.
Yeah.
That's the time between getting infected and when the test can actually detect it. For some STIs, this can be weeks or even months. So a negative test soon after exposure might need repeating later. And often, blood tests are used alongside other tests like urine tests or swabs.
Okay. What about the coagulation panel? What's that looking at?
That panel assesses how well your blood clots. It usually includes tests like the PT or prothrombin time.
Which is reported as the INR sometimes.
Exactly. The INR, International Normalized Ratio, is a standardized way to report the PT, especially important if someone is on warfarin anticoagulant therapy. The panel also often includes the APTT, activated partial thromboplastin time, which assesses a different part of the clotting process, and sometimes fibrinogen levels.
Why is this important?
Well, you need your blood to clot to stop bleeding, obviously, but you don't want clots forming inside blood vessels where they shouldn't. These tests help diagnose bleeding disorders, monitor blood-thinning medications, and assess clotting risk.
Okay. Two more specific ones mentioned were DHEA sulfate and CRP. What about DHEA sulfate?
DHE sulfate is a hormone mainly produced by the adrenal glands. Testing its level can be useful if you suspect problems with adrenal hormone production, particularly excess androgens. For example, in women with symptoms like excessive hair growth or male pattern baldness.
And C-reactive protein, or CRP.
CRP is a marker of inflammation in the body. It's an acute phase reactant, meaning its levels go up pretty quickly in response to things like infection, injury, or autoimmune flares.
Is it specific?
No, that's the key thing. It tells you there is inflammation somewhere, but not where or why. Mild elevations can be seen with lots of things, even obesity or depression. Very high levels are more suggestive of significant infection or inflammation. There's also high-sensitivity CRP, hsCRP, which measures very low levels and is sometimes used to assess cardiovascular risk, though its exact role is debated.
Right, so many tests covering so many areas. It really underscores how central blood testing is, especially for ongoing conditions like chronic diseases.
Oh, absolutely indispensable. For managing diabetes, we rely on HbA1c. For chronic kidney disease, we track creatinine and electrolytes. For heart disease, lipid panels and maybe inflammatory markers. For deficiencies like vitamin D or iron, specific tests. For autoimmune diseases like rheumatoid arthritis, autoantibody tests.
So it's about tracking progress and adjusting treatment.
Exactly. Regular blood tests let you see how the disease is behaving, whether the treatment is effective, and if any changes are needed. It's crucial for long-term management and improving outcomes.
So, wrapping this up, the big picture is that blood tests are this incredibly powerful, versatile tool. They give you a window into so much of what's happening inside the body.
That's the perfect summary, a cornerstone of medical practice, really, giving you insights across almost every clinical situation imaginable.
And the crucial point, especially for anyone learning this, is that you can't just look at a number in isolation, right? You have to interpret it.
Absolutely. The numbers need context. What's the patient's history? What did the physical exam show? Are there other test results? You have to put all the pieces together. Discussing results with the healthcare provider is key.
And if you want to learn more about specific tests, that resource Lab Tests Online sounds useful.
It is, yes. www.labtestsonline.org.uk. Very helpful for getting detailed information on individual tests.
Excellent. Well, that's been incredibly informative. It makes you wonder, doesn't it? Given how much we can learn from blood now, what might future diagnostic techniques unlock? What other secrets about our physiology are waiting to be discovered?
It's a fascinating field, constantly evolving. Who knows what we'll be able to measure routinely in the future?
Something to think about. Thanks for joining us for this deep dive.